Welcome back to PedsCrit. I'm Zach Hodges.
And I'm Alice Shanklin. Today, we're talking about continuous renal replacement therapy. I love this episode because it starts with the basics and then really goes all the way to what's coming next for critical care nephrology.
And to that, we have Dr. Stuart Goldstein. He's a professor of pediatrics at the University of Cincinnati, where he serves as the Clark D. West Endowed Chair. And he's a practicing pediatric nephrologist at Cincinnati Children's, where he's also the director of Acute Care Nephrology and the medical director for the Pheresis Service. Dr. Goldstein is well published in the areas of critical care nephrology, including over 300 journals and serving as editor in multiple textbooks. Specifically, he's researched novel urinary AKI biomarkers and CRRT. He is the person that we want to talk to when it comes to this topic today.
Yes, and we are so grateful for Dr. Katherine Melink for reaching out to us and saying, hey, cover this topic, and I've got the guest for you. Dr. Katherine Melink completed med school in her hometown at the University of Cincinnati. She then stayed for her general pediatrics residency at Cincinnati Children's, where she was able to conduct research in biomarkers for the prediction of kidney injury in critically ill children, particularly critically ill children in the CICU. Katie's exposure to CRRT under physicians like Dr. Goldstein really served as her motivating factor to participate in this episode, and she will be starting PICU fellowship at Boston Children's in July.
Yes. Thank you, Katherine Melink. Thank you, Sue Goldstein. Let's get right to the topic.
Dr. Goldstein, thank you so much for joining us today. Our listeners have already heard your bio, but we'd love for you to tell us who you are and then also something you enjoy outside of medicine.
Oh, great. Well, it's my pleasure to be here, and I love speaking with critical care attendings, but really more so critical care fellows, because they're the ones who are on with me at night. So I'm the director of Center for Acute Care Nephrology at Cincinnati Children's Hospital, and the center was developed in 2010 to really integrate and harmonize all clinical care research, quality improvement initiatives for children with or at risk for acute kidney injury. So that's what I do. And outside of medicine, I'm a guitarist, and I always say if I could have played guitar like Frank Zappa, you would have never known me. So I guess fortunately for critically ill kids, I'm not that good of a guitarist.
That's fantastic. And we're also happy to have Katie here today. Katie, introduce yourself.
Hi, my name is Katie. I am a third-year pediatrics resident at Cincinnati Children's and have been fortunate to get involved in AKI research and looking at some biomarkers, which is what brought me to this podcast episode. My favorite hat to wear is being the aunt to 3 rambunctious nephews under the age of 3. So 2 of them live here in Cincinnati, and I've gotten to spend much of my time with them, but I'm excited to move to the Northeast where the youngest one lives. So I'll be going there for fellowship.
Fantastic. And Dr. Goldstein, will you tell us how you became interested in this niche of critical care nephrology and maybe highlight some of your current research interests?
Sure, Zach. Thanks. So back in the dark ages before any of you were born in 2000, acute kidney injury was termed acute renal failure, and nobody really wanted to study acute renal failure. No one likes to study a failing organ. And around that time, there was a huge move to start to actually standardize the definition. And it was adult colleagues, a combination of intensivists and nephrologists, so Claudio Ronco, Ravi Mehta, nephrologists, and John Kellum and Ronaldo Bellomo, adult intensivists, who really created the field of critical care nephrology. And the first thing that they did was to finally standardize the definition and change the term from acute renal failure, which implies that a patient requires some sort of dialysis support therapy, to acute kidney injury, where it was becoming pretty clear that even small changes in serum creatinine or periods of oliguria were associated with poor outcomes. So I was interested in that just because there was a huge gap in the field, and I was at Texas Children's Hospital right after my fellowship in the Northeast, and we were doing a lot of CRRT, and it just seemed like an area where a pediatrician should be part of it. So I was just kind of the token pediatrician getting interested in the field and starting to participate in the transformation of the field to acute care nephrology, acute kidney injury, and all of the therapies that we're able to provide now.
Oh, that's awesome. And we are grateful for that rebrand. Before we get started today, do either of you have any conflicts of interest that we need to disclose?
My only conflicts are that I consult for a number of companies, industry sponsors that market either biomarkers or CRRT-related devices. If I'm asked to speak about one of their products in particular, then I will tell you the conflict that I do or don't have.
Okay, that's very fair.
Thank you. Katie, do you want to give us our case and our first question today?
I'd love to. So our case is a 10-year-old male with septic shock, intubated and requiring multiple antibiotics and vasoactive infusions, has progressive fluid overload, peripheral edema, and rising serum BUN and creatinine over the first 3 days of his ICU admission. Over the past 12 hours, his urine output has fallen below 0.5 mLs per kilo per hour, despite use of IV diuretics. The ICU team is considering using CRRT for the management of his AKI and fluid overload.
So this is a case that we see pretty commonly in the ICU. Dr. Goldstein, to get us started, would you just please define exactly what is CRRT?
Sure, Zach. So CRRT stands for continuous renal replacement therapy, and it's a form of dialysis that is reserved for patients who are critically ill who can't tolerate an intermittent form of therapy such as hemodialysis. And by tolerate, I mean being able to handle the blood pump flows that are associated with those machines, as well as the volume that may need to be removed in a short period of time. So CRRT is a gentler 24-hour continuous therapy that also allows for minute-to-minute, hour-to-hour management of the patient.
And now, as we think about the concept of CRRT and dive down into the different important subcategories, how would you define the difference between ultrafiltration, diffusion, and convection?
Great question, Alice. Thanks. So we discussed these in terms of modalities of CRRT. Ultrafiltration just means the removal of plasma water. So it's just fluid removal without any clearance. Now, if I were to remove or ultrafilter a liter from myself, I would remove not only that liter, but also the BUN, creatinine, potassium, small solutes that are in that liter of fluid. When we start adding clearance, either diffusive clearance or convective clearance, then we're increasing the small solute removal. The two types are convection and diffusion. Convection is termed continuous veno-venous hemofiltration. And the way I describe convection is if a person is a coffee drinker. So if we think about putting coffee grounds in a filter, the filter is a semi-permeable membrane. We put the coffee grounds on that filter, and either if we have a fancy coffee maker like I know you all do, like a French press, you push that fluid through there, or if we just have an old-time Mr. Coffee and we have gravity drag the coffee goodness into the pot, that is convection. So we're convecting across the filter. Now, diffusion is like being a tea drinker. So if you have tea leaves and you have them in the tea bag and you put that bag in hot water, then the tasty tea goodness is going to go from high concentration in the tea bag going across by a concentration gradient into the water in the tea cup. And so that's diffusion. And that's called or termed continuous veno-venous hemodialysis. So you can even do both, where you do diffusion and convection, and that's called continuous veno-venous hemodiafiltration. So you can do CVVH and be a convector, you can do CVVHD and be a diffuser, or you can do CVVHDF and be a confuser.
That's nice. Perfect. I think this is really helpful. So maybe to read this back to you. So ultrafiltration really is just removal of plasma water, so removal of fluid. And then to improve your small molecule clearance, you either need diffusion. That's your brewing a tea with a tea bag. I really like that analogy. And then, or convection, where you have that maybe that pressure where you're pushing maybe the French press down in the coffee analogy that you use. As a lowly intensivist, what difference am I going to notice in my patient who maybe is receiving diffusion versus convection in their clearance?
Yeah, so in terms of small solute clearance, again with CVVHD or CVVHDF, there's absolutely no difference in small solute clearance. And that's because diffusion is based really on Brownian motion of the molecules. So small molecules will just bounce around and get through the pores pretty quickly. Larger molecules, however, even though they could fit through the pores because they're lumbering and not moving so quickly, so larger molecules may not diffuse as well. However, in convection, while small solute clearance is exactly the same as diffusion, convection will have better clearance of what we call middle molecules, so molecules that are in the 5,000, 10,000, or 15,000 Dalton range. So you as an intensivist may not notice the difference, even those of us who are nephrologists may not. But the reason some people want to do some convection is the thought that if there's an incremental benefit in removing these middle molecules, most notably pro-inflammatory cytokines, then possibly having some convection could be helpful. There's never been a study to show that CRRT with convection improves survival compared to diffusion, but there are some observational data that it may provide an incremental benefit. So if you can do it, and all machines now can do that for the most part, then some people will often combine diffusion and convection.
That's interesting. And I have noticed locally that we do both diffusion and convection most of the time. Is that common across the US, or is it all just style?
I think most of it is just style right now. It used to be really important, again, before you guys were born, because the machines were not as efficient, and the prescriptions, we really didn't even know the dose. When we talk about dose, it's the effluent dose, the amount of fluid that is going across the membrane or in diffusion passing through the membrane. And so in the adult world, it didn't matter if you were a 50-kilo adult or a 200-kilo adult, everyone got the same prescription of about 1 or 2 liters of effluent per hour. We as pediatricians have always been way ahead in the CRRT field because it's in our DNA to dose by weight or by surface area. So we've thought about this long before. And so now that adults are dosing by weight, and now that the machine technologies can deliver these huge doses, it's become less and less of an issue whether you do convection or diffusion. And it tends to be local practice. However, I would tell you, if any of your attendings tell you whenever you go anywhere that there is one that is absolutely better than the other, they're absolutely wrong. So just do what you do best and what is the standard protocol. Most important thing is when I'm not in Cincinnati and someone else is rounding as the attending, it should be the same prescription. We should individualize care. We should not individualize the prescription based on what the physician thinks.
Fascinating. You know, we've kind of mentioned it briefly, but in some of these modalities, there's dialysate fluid. Sometimes there's replacement fluids. So what should I make of that? What are the differences?
Yeah, so when you're prescribing CVVHD, you're prescribing a dialysis fluid rate, and that's the amount of fluid per hour that goes outside of the intraluminal space of the dialysis membrane on the other side of where the blood is, and then that goes into the effluent bag. And replacement fluid is the amount of convective fluid that goes into the intraluminal side of the filter, and the machine ultrafilters that volume of fluid off into the effluent. And so when we talk about dose, we talk about a total effluent rate. What is the replacement fluid rate and what is the dialysis fluid rate? And we add those together, and then we dose it based on patient size per hour.
Fantastic. I can feel myself getting a little too excited about the details of CRRT. Katie, I really hope you can bring me back down. Give me a good clinical question, maybe number 4 on the script.
Well, Zach, you can never get too excited about CRT. I'm sorry. I don't even know what that means.
Dr. Goldstein, what are the common indications for CRRT in the PICU?
Yeah, so I think as nephrologists, we have to think about patients who are acutely ill. So nephrologists also, obviously, we take care of patients with end-stage kidney disease who need to be on a maintenance dialysis therapy, either peritoneal dialysis or hemodialysis. And that's a huge fork in the road for a life for that patient because we're committing them to decades of dialysis or transplant. And usually in those situations, it's refractory hypertension and electrolyte imbalance that can't be managed with medications and with diet, or uremia. If we wait for those indications in acute kidney injury to start CRRT, then we're waiting far too late. We have to think about patients acutely. So the standard indications would be all of those things if a patient dropped out of the sky into your ER and then into your ICU to start dialysis emergently. But in the pediatric world, we've really learned that fluid accumulation to the point of fluid overload has become really the standard for starting renal replacement therapy. And the reason we say that is all of the epidemiologic data from acute kidney injury, both in adults and from our large AWARE study a number of years ago, show that a doubling of creatinine or 12 hours of oliguria is independently associated with mortality. Now, when a patient doubles their creatinine, they're not severely acidotic. They don't have a BUN of 200. They are not hypocalcemic. This is telling you that acute kidney injury in the ICU is a systemic disease. It's a vascular organ and usually part of multi-organ failure. And as urine output is one of the two criteria for acute kidney injury, what we've also noticed is that in CRT, patients who do not survive their CRT or ICU course in every study have been more significantly volume overloaded than those who have survived. So we now start to think about targeting 10 to 20% volume accumulation as an indication to really consider CRT for the individual patient. It's also important to know that, again, volume overload, it really integrates oliguria, or at least relative oliguria, of the patient into that volume accumulation equation. But volume accumulation also leads to a dilution of serum creatinine. So if a patient is really horribly volume overloaded and you say, well, their creatinine hasn't doubled, well, that may be because their creatinine's diluted. And you could say, well, Stuart, I don't believe that. That doesn't make sense. Well, I would say if a patient is very dehydrated and their creatinine is elevated, you say, well, that's just because they're hemoconcentrated. So it's just the opposite, but people have a hard time accepting that. But it's the same sort of paradigm. So for me, honestly, Katie, if a patient has a creatinine that's gone up by 50%, but they have 15% volume accumulation and they're on a ventilator, you have to give me a really good reason, especially if they have septic shock and multi-organ failure, why I'm not going to start CRT that day.
Dr. Goldstein, can you talk to us about how you're defining that 15% fluid overload?
Yeah, it's based on volume accumulation from ICU admission to whatever time point you are in the ICU. And we never thought after our first small study now 24 years ago that this equation would hold up so well, but we look at fluid in from ICU admission to CRT initiation in liters minus fluid out from ICU admission to CRT initiation in liters divided by their ICU admit weight. We don't care what happened in the field, in the ambulance, in the ER, in the elevator, in the hallway. We figured they were being resuscitated. We want to see what's happening from that time point to when we start CRT. Now, I called it fluid overload when we wrote our first paper, again, 25 years ago, and the recent 26th Acute Disease Quality Initiative, or ADQI, was the first ever pediatric ADKey, and it was the 26th iteration. And it was all pediatricians except for a few adult colleagues who like to think that they're honorary pediatricians. And we really understood that what we should be talking about is volume accumulation as that metric, and then volume overload or fluid overload. Is there an associated physiologic impact? So patient's oxygenation is being impaired. The patient has abdominal compartment syndrome. And I think that really, not all fluid accumulation is fluid overload, but then it makes us think about the patient as a whole. Now, others have also done a calculation based on changes in weight. So ICU admit weight, especially if the patient doesn't have a Foley. So they may look at bed scale weight. And again, and Dave Selesky from Michigan is the one who's really championed that. And while you may get slightly different numbers, the associations are just as strong. So either weighing the patient from ICU admission or calculating their ins and outs and dividing both of those by their admission weight get us to the final answer.
This is great information. And, when I reflect on just walking through the ICU, if you want to start talking about margins cutoffs of like 10% fluid overloaded, gosh, this is a significant proportion of our patients. Dr. Goldstein, I wanted to know, do you use any other concepts other than maybe clinical trajectory and percent fluid overload to help make your decision for dialysis? And the questions that come to mind for me are biomarkers, maybe like outside of our traditional creatinine BUNs, maybe NGAL, maybe cystatin C. And then do you also consider an appropriate diuretic challenge?
Yeah, so great question, Zach. So yes, we've been fortunate here to have NGAL, so neutrophil gelatinase associated lipocalin, as an AKI biomarker. And so here's my first conflict, Zach, Alice, and Katie. I consult for Bioporto Diagnostics Incorporated, who market NGAL in the United States. They've funded my research. And in fact, we completed the derivation and validation studies, the earnest and guidance trials in the United States that have led to clearance of NGAL for children who are critically ill to aid in the risk assessment of acute kidney injury. And FDA cleared this in 2023, and I'm proud to say it was cleared in children before adults. So again, we're always ahead of adults, right? So that's great. We absolutely do use NGAL to help in the decision making. Now, we don't dialyze a patient just because their NGAL is elevated, and we don't ignore a patient just because their NGAL is low. But in our first work in a publication from Chuck Varnell, who's a colleague of mine when he was a fellow here, when we started using NGAL, we found that decreasing NGAL was really helpful in helping us de-escalate from renal replacement therapy. We felt pretty comfortable that we could stop CRRT or that we give the patient a day or two off of acute hemodialysis because we felt the patient would recover their urine output. But we have a very, very structured program now where we have an automatic risk stratification system that we invented here called the Renal Angina Index. And it is automatically calculated and it has resulted in our EHR. And then NGAL is automatically ordered. There's a reflex order or conditional order that is released if that number is greater than or equal to 8. And this has been called the Taking Focus 2 study, and this was published at the end of last year. And just to give you a high level, that risk stratification with the RAI plus NGAL helped us with our intensivists to really guide therapy to determine who would or be considered for CRRT initiation if patients got to 10 to 15% volume overloaded. And what we found was instituting this, we started CRRT 2 days earlier. Patients were on CRRT for 5 days fewer. Survival increased significantly for CRRT patients, although I want to be very careful that this was a single center study. But total ICU length of stay and ICU length of stay after CRRT discontinuation went down significantly by nearly 11 days. And so we're very hopeful as we roll this out to other institutions that this kind of risk stratification will give intensivists the confidence that CRRT initiation really makes sense for that particular patient. We called it renal angina because we were recapitulating the acute coronary syndrome. So patient has cardiac angina, so they have the right Framingham risk factors. They have the chest pain. That's who you get a troponin in. If you're healthy, like all three of you are, and I can see you, you're all incredibly healthy, and you are shoveling snow. Well, you wouldn't be shoveling snow in Texas, but let's just say you're shoveling snow on a cold winter day and you have chest pain, you're not having an MI. You tore an intercostal muscle. Likewise, if an adult who is a diabetic and obese and smoker shows up to an adult ER with toe pain, they're not having the right symptoms, so you wouldn't get a troponin in them. And what we've wanted to do with NGAL and this risk stratification is really identify the patients who should have a biomarker, and from them then determine, okay, we have a high pretest probability. What does the patient need to do over the next 24 hours? Now that they're 10% volume accumulated, what do they need to do? And so that's to your next question, is the furosemide stress test. I think every patient should get a dose of furosemide, and every patient should get a big dose of furosemide, and that's why my friend Ming Chawla called this the furosemide stress test, more cardiology envy. It's a 1 per kilo dose. It's a diagnostic dose. It's not the dose you will ultimately give. But if a patient doesn't respond to that, and for us and kids, that's 3 to 4 mils per kilo per hour of urine output over 2 to 4 hours, that patient is not going to respond to a higher dose. They're not going to respond to an infusion. They're not going to respond to Bumex. It's time to then think about CRRT. So it's not an either or, it's an escalation of care. And that's how you think as intensivists. You don't think of one thing or the other. Patient is on BiPAP. Well, that's not working, so let's escalate to invasive mechanical ventilation. Well, IMV's not working. If you're in the NICU, well, then go to an oscillator. Or does the patient need to go to ECMO? You think like that all the time. But in nephrology, it's like, oh, it has to be an either or. No. Fluid restriction, you're not going to fluid restrict the patient in septic shock. And once they're resuscitated, try diuretic. If that works and you can keep them fluid balance even, continue that. But if it doesn't, then it's time to escalate to CRRT.
Wow. That's really powerful information. I have to ask, where do you max out your Lasix for the furosemide challenge?
Yeah, so it's a 1 per kilo dose. And again, it's just a diagnostic dose. So if patient responds, then I would go to half per kilo, 3 times a day or something like that. If a patient has seen a diuretic in the previous 3 to 4 days, then we'll give a dose of 1.5 per kilo, and we don't max out the dose. We give the dose. Now, if we have, say, an obese adolescent, I might, use their ideal body weight or something like that, if that's the question you were asking. But generally, I've never had to really give more than 120 milligrams.
Wonderful. And then, just in case we've never seen the NGAL lab result before, can you talk about what numbers you're looking at and the units and what's concerning?
Yes. So normal urine NGALs run less than about 25 to 50 nanograms per ml. The current test that is available in the United States and was studied, the lower limit of detection, what'll get reported is 50 nanograms per ml. The current ranges we use are, if it's greater than 150 nanograms per ml, we consider that to be positive. These numbers can go up into the thousands. And honestly, I don't know if there's a difference between 6,000 nanograms per ml and 3,000 nanograms per ml, but we do watch those trends. But I'll tell you that the number will be slightly different than the 150. Those data aren't out yet, but they're not going to be much different to rule in the terms of stating that, this patient is at higher risk of developing stage 2 or stage 3 KDIGO AKI.
Excellent.
So maybe just describing, we have this patient in the ICU, they have septic shock, they have maybe 15% fluid overload. We get a urinary NGAL, it's elevated, you give them a slug of furosemide, 1 per kilo, they don't respond. Gosh, that feels like a slam dunk choice. We're going towards CRRT, if it's in line with the patient's and family's wishes and our direction for their care. You mentioned, Dr. Goldstein, a lot of key studies thus far. Any other key studies that you wanted to highlight that really direct our clinical application of CRRT in the ICU?
Yeah, so I think the overwhelming, data show that volume accumulation is really the marker that we should use to start renal replacement therapy. I'll tell you, our adult colleagues still haven't necessarily bought into that, and they've done these massive multi-center randomized trials based on initiation, either in timing, like, hourglass time, or stage 2 or 3 creatinine time, and they've all come out negative. And some of them are friends of mine, but they're all adults, so they won't be listening to a pediatric podcast, so I'm fine. But I think those were all misguided. And I've told them that. I think a really nice study was published in JAMA Peds a few years ago by first authors Rashid Alobadi, Sean Bagshaw, who is my friend who's an adult intensivist who did the START AKI trial, that randomized trial that was negative. Raj Bazoo is on that, as well as Aaron Stenson, both pediatric intensivists. And that was a really beautiful systematic review of all volume accumulation data, not just for CRT, but also for PD after cardiopulmonary bypass, showing always that more fluid overload, more volume accumulation was bad. It was never better. Because as an intensivist, reflexively, and rightly so, you would say, well, that patient needed the fluid. But if that patient needed the fluid, then I would have thought patients who got more fluid would have done better. But the fact that they got the fluid and they became more volume accumulated and couldn't get rid of the fluid, that is, to me, that's acute kidney injury. That is an organ that is either hibernating or just can't function. And so it's the accumulation that is really the bad part. Now, you could say, well, I'm a skeptic and I need a randomized controlled trial to demonstrate that 10% versus 25% volume accumulation really is important. Well, that horse is out of the barn. We have no equipoise anymore. I can't go to the mom in bed space 1 and say, I'm at UT Southwestern, I'm a really good intensivist, I have really good nephrologists, and your child has septic shock and is 10% volume overloaded, and we're going to start your child on CRT. We know how to do this, and will you sign up to be in that trial? And that mom's going to say, yeah, and then go to the dad in bed space 2 and say, hey, I'm at UT Southwestern. We're really good. We've got these great nephrologists. We know how to do this, and I'm going to let your child get to 25% volume accumulation, and that's an 8 times odds ratio for mortality just to prove a point. We can't do that. I think that JAMA Peds paper really shows that volume accumulation is the enemy here. And if you read the Taking Focus 2 study, I think we now have tools to help us really be even more refined and personalized for when we should start. I'll point out that not all patients who are renal angina positive and NGAL positive went on to CRT in that study. The physicians had choice, of course. But what they did was we identified the patients who needed it sooner, and they started it sooner. They got it for a shorter period of time, likely because they didn't get so volume accumulated in their lungs, in their abdomen, and they were able to get out of the ICU if they survived their underlying illness.
Now, as we think about an earlier initiation, or as you try and change that framework, what are the downsides of CRRT that you're thinking about for patients, that intensivists might be thinking about? What risks are we balancing?
Yeah, so it's the risk of a catheter. So you have to put an additional catheter in. And I think, early on, I didn't really understand the perspective of the intensivist. And so what I mean by that is, the intensivists have done all this great work about early, goal-directed therapy and rapid volume resuscitation. And you guys have done all this super awesome job of resuscitating a patient. And then you think, I'm not going to consult Stuart Goldstein to come in and start CRT because he's going to reverse that and just rip all that fluid off. And I did not understand that. And that is actually something that, my friend Ronaldo Bellomo is starting to write about, called dialytrauma. And there is dialytrauma, especially in a kidney or kidneys that are recovering from acute tubular necrosis. if you remove fluid too quickly and cause repeated hypotension, those kidneys are going to have a harder time actually recovering. And so I think the important change, Alice, and maturity I had to develop over a few years was if you start earlier, and what I mean by earlier, again, these patients are still 10 to 15% volume accumulated. I don't take any net fluid off the first day. I keep the patient even, but I'm your partner in this, and I want you as the intensivist to be able to give all the blood products, nutrition, and medications the patient needs without having to volume restrict and preventing further volume accumulation. It's really more of a volume homeostasis at that point. You've resuscitated the patient is not out of shock, but I can tell you if I can control the acidosis, your vasopressors are going to work better. And you can start giving the patient optimal nutrition that day. That patient has ongoing blood product needs. You can give those blood products and you don't have to worry about the potassium or the additional volume. So I don't want to cause dialytrauma. And in fact, if we start early enough, I almost never take net fluid off the first day or two. CRRT initiation should almost never be an emergency, except for that patient who drops out of the sky. We should know about the patient. And what happens here now is we'll get a call from the intensivist. Hey, we have this patient with gram-negative shock. They always come in at 7 or 8 p.m. I don't know why, but they always do. And we're just letting you know about the patient. We're resuscitating, and we just want you to come round with us in the morning because once they're resuscitated, we'll have to see if we think this patient needs renal replacement therapy. And it is almost as beautiful like Oz that here. We almost never get consulted way late anymore.
That's so interesting.
Yeah, I think having that ongoing communication and getting the catheter in the kid and being able to start dialysis right when they need it, that's a big deal. It helps us deliver care to these kids safely and effectively. And it seems like you guys have done a really great job. And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.